This is a proposed study. So that's why I wore casual clothes today in case I spilled water. This is a proposed study, so if you were hoping to get the answer, you might get a jump start on the coffee break. On the other hand, if you do stay, and I admire the endurance of those of you, this is the third day, right? If you do stay, you could have a little impact, perhaps, on some of the quality of life measures that we're going to assess. So, Pregabalin is the generic name for Lyrica on spasticity and function in transverse myelitis patient. Now, there are lots of drugs for spasticity. Some of them have sedation, work by a central effect. Others, one in particular that works within the muscle, they'd like you to think that it works only on the spastic muscles, but in fact it works on all the muscles. It can't tell the difference, so there are limitations. So Pregabalin is an approved drug, but not yet for spasticity. It's approved by the FDA for treatment of post-herpetic neuralgia, pain associated with diabetic peripheral neuropathy, and as an adjunctive therapy for adults with partial onset seizures. What is it? It's a GABA derivative, GABA being gamma-aminobutyric acid. Selectively binds to, this will make your eyes glaze over, the alpha-2 delta subunit of voltage-gated calcium channels. And if you ask me what that means, then I'll give you the famous Yogi Berra answer. You can look it up. So it modulates the influx of calcium in hyperexcited neurons. I just hate it when my neurons get hyperexcited. So it may, we should say might, diminish spasticity and enhance function in patients with upper motor neuron lesions. Thereby diminish depression, anxiety, improve perceived quality of life. Now, there's a touchstone of research that I learned a long time ago, and I still like it. The touchstone is threefold. Is it new? Is it true? And so what? So the so what factor, if we decrease spasticity, then so what? Does the gait improve? Do you sleep better? Are you, less depressed, less anxious? Do you have an impression of your overall improved quality of life? Now, it's quite selective, and that selectivity of pregabalin should result, we trust, should result in fewer side effects than the other commonly used medications for spasticity. And it is more potent, has more potent activity at the calcium channels than gabapentin. The other name for that is Neurontin. So in the studies that have been done, less interpatient reliability in terms of dose requirements. And that's important when you're going to do a study. If the persons taking this, have wildly different dose requirements, it's very, very difficult to have a so-called standardized dose. So we refer to that as a linear pharmacokinetic profile. Some of you have experience with the drug dilantin, and you might know or might have experienced that it has nonlinear pharmacokinetics. And so dilantin is one of those drugs where a little doesn't do you a little good. You have to be therapeutic. And it's, again, one of those where you give it, nothing's happening, a little more, nothing. As far as the blood level goes, then all of a sudden, zoop, you're way up into the toxic range. So this is just the opposite. It's linear. It also allows greater potency at lower doses. while staying within a safe range. So the drug itself looks to be quite safe, quite easily handled. We don't know yet whether it's going to affect spasticity as we want it to. I don't need to tell you, there was a workshop on spasticity here. Some of you who kindly volunteered in the bracing workshop, one of the main problems you had was spasticity, so I don't need to dwell on how it adversely affects your quality of life. This is the so what factor. So if it does decrease it, we think it'll decrease depression, anxiety, and improve the quality of sleep. Now, with transverse myelitis, there are studies that show this, but the last time we had one of these seminars, Adam Kaplan gave an excellent talk on the high prevalence of clinical depression in transverse myelitis. And it's equal to or greater than that seen in multiple sclerosis. Incidentally, for those of you with experience with multiple sclerosis, there's something that's still in the literature, and it talks about euphoria. I don't think I've ever seen a patient with multiple sclerosis with euphoria. It's sort of like your life, your quality of life is knocked into a cocked hat, and whoopee, aren't we having fun? I don't think so. If it does occur at all, it is late, and it might, in fact, be a side effect of the steroids that are sometimes used. And transverse myelitis, which is the demyelinating disease that we're going to be studying, at least initially, does have a high incidence of depression. Now, if it is effective in transverse myelitis, then there are all sorts of disorders with spasticity that it should help. This is going to be the kind of study that's considered a gold standard. That's one of the nice things if you do it in advance. This is a drug that's not terribly widely used yet, and used essentially not at all for spasticity. So this is going to be a randomized, double-blind, placebo-controlled crossover. We're only going to do it at Johns Hopkins for now, and this is going to be what would be considered a pilot study with 40 subjects. I have several specific aims. How am I doing for time? Okay, we're still okay. To determine whether treatment with pregabalin will reduce spasticity of the gastrocnemius. We don't have tools for measuring spasticity all over the place, but we do have, we sort of had the football in that there are only 3 of these in the world. If time allows, I'll show you the setup for assessing quantitative assessment of spasticity in the gastroc, the calf muscle. We want it to be in patients with impaired ambulation, and we hope that it will lead to improvement in gait. So if you look at the continuum of impairment, decreased function, and decreased participation, this would have 2 effects right there. The impairment would be the quantitative decrease in spasticity. The improvement in gait would be the improvement in function, and then the quality of life, the participation. So we think it will do that and have those secondary effects. One of the things that we think that it will have this effect, this water that I spilled is spilling on my foot. Never mind, we just carry right on. All right. So not only do we think that it will decrease the gastrocnemius spasticity, we think it will improve the strength in the tibialis anterior, the antagonist. And this is very important in gait. Dr. Pidcock was telling you something about the gait. And timing is everything. Have you seen those ads on television where this guy, I forget the company it's advertising, but it says timing is everything. And so he drives through the toll gate, And a few yards down, then he throws out some coins on the tarmac there. What I really like is he's with his girlfriend, this candlelit dinner. And she says, "I love you." And he sits there smiling. She pretty soon gets mad, storms out. He says, "I love you too." So timing is everything. And we will not only be looking at isometric strength of the tibialis anterior, but we will look at it at higher contraction velocities. Remember when we were talking in the bracing seminar, it said spasticity is a velocity-dependent increase in resistance to passive stretch. So when the tibialis anterior, the dorsiflexor of the foot, go to contract and clear that foot in swing phase of gait, and the gastrocnemius fights it, it can't do it fast enough. And you're either going to have to circumduct that leg or hyperflex the hip or do something dangerous like dragging the toe. We saw one of the volunteers with that problem as well. So we think this is going to have a very favorable effect on gait. The second specific aim to investigate, here's the so what factor, whether the reduction in spasticity will lead to improvement in perceived quality of life and decreased depression and anxiety, also sleep. So this is just the implication of that. The hypothesis is the implication of the specific aim. It'll only be patients with diagnosed idiopathic transverse myelitis, pretty wide age span there, 18 to 70. So if 71 comes along in volunteers, we're probably going to sneak them in. So if they have criteria for MS and these others, history of SLE, known hypersensitivity to pregabalin products, then that would exclude them. Renal failure, active infection of the central nervous system, uncontrolled hypertension, congestive heart failure if it's acute and not stable. This is the protocol. This is a little bit tedious spending time, but we wash in the drug at a lower dose, then go to the higher dose, 150, weeks 2 through 5. It could be either the sugar pill, placebo, or the pregabalin. The patient doesn't know. The people doing the tests of strength and spasticity and gait don't know. That's what's meant by double blind. We wash it out for a week at the lower dose, and nothing, no drug or placebo for the 7th. And then we cross it over and repeat the whole thing with the opposite or the alternate treatment. Total study time, 14 weeks. This is what we're going to assess. Quantitative muscle tone, and I think I have time to show you a little bit about that. The gait right. Dr. Pidcock just mentioned the gait right. Qualitative muscle tone, the modified Ashworth scale. That is to give it something known as face validity. The lower limb spasticity measurement system that we invented at the University of Washington in Seattle is going to give you a reliable quantitative measurement. But this is to say, well, are we measuring the right thing? So that's the face validity. Muscle strength at different speeds, health outcomes for pain, depression, quality of life. So the MAS, qualitative only, is just an ordinal scale, but it does provide the face validity. Do not adjust your television sets. This is a little bit fuzzy, and we couldn't make it much clearer. But this is a schematic of the tone assessment device, and it has a very nice ability in that you can tease out the elastic stiffness from the viscous stiffness. The elastic stiffness is in proportion to displacement, how far you've stretched it. The viscous stiffness is in proportion to how rapidly. So as we go progressively more rapidly, it will go up. It won't in patients without spasticity. This shows you the average elastic stiffness versus frequency, frequency being how fast you go. This used to be called cycles per second, which was a little easier to understand, but it's been renamed after a man named Hertz. So from 0 to 12 cycles per second, and we really only go from 3 to 12 cycles per second, called Hertz. Okay, so you have spastic subjects. You have spastic subjects with a temporary block done by yours truly, and then normal subjects. This thing that I call the gull wing up here at a certain frequency, about 7 hertz, is analogous to what happens, in the movies. It looks as though the wagon wheels are going backwards. Well, they're not going backwards. It has something to do with the sample cycling frequency. And at this point, the spasticity, this frequency, the spasticity is actually helping this device that moves it through. But when you block you do a tibial nerve block and block the gastrocnemius, then it drops down to where it's parallel with the normal. Now you see, here it doesn't change as you go faster and faster because it's just displacement. But it takes a higher force, that is, it's stiffer than the normal, even after the block. And we call this incipient contracture. Some of you will have experience with spasticity, and some of you will have experience with contracture, which is a relatively fixed soft tissue limitation of motion. This is the average viscous stiffness versus frequency for 13 healthy and 13 spastic subjects. This is without the block. You can see that's really high. It's really taking the force, and the higher the frequency, the higher the force that's required. In the case of viscous stiffness, you block the nerve, and it comes right down to the normal. So this is where we are hoping to see a change with the pregabalin. And if you plot the viscous against the elastic stiffness, you can get something known as the Nyquist path length, and that represents the gain on the system. And that's a very important thing. Here's a diagram of persons with spasticity with nerve blocks and without nerve blocks. So this is the gain on the system, and we hope that we will see it under pregabalin move. It won't go this completely, but move toward that much shorter path length. So results. Well, as I told you, this is a proposed study. No results yet. We're going to submit this to Pfizer, the manufacturer of Lyrica. And how many of you here, if you were the president of Pfizer, would give us some money? All right. Hey, let's see those hands. Okay, very good. So I don't think we need to go any further than this, but we do have a minute or so for a question or a comment. I would take either one, but I'd like to ask you all a question. Are we looking at the right things? I mean, we have to look at spasticity, but as far as quality of life and gait and that, are these relevant things? Yes. Okay, all right. Yes, sir. I'm not sure who had his hand up first, but I think you did, and then right here.
I started taking Lyrica in November last year.
Yes.
And I just have a comment. That is that it didn't do anything for me for spasticity, but it decreased my pain. My quality of life is terrific.
Okay, that's good. Anybody from Pfizer here? Okay. Don't tell them that until after they give us the money, okay? Because they'll say, we already know it decreases pain. We're not giving you any dough for the study. Yes, sir. Okay, so it was roughly equivalent. Okay. Oh, without the, oh, all right. We want Pfizer to hear that. Excellent, excellent. Okay. You know how times have changed. I'll get you just a comment. When Dr. Lehman and I were studying the effects of or just the temperature distribution with some of the diathermy machines several decades ago, Dr. Lehman would not even accept the loan of a machine from a company. He paid fair rental value. Money is a lot scarcer today, and so we would insist on having the freedom to publish the results. If it doesn't do anything, then we want to publish that. But having said that, we need their money.